So there are many definitions of integration, and this is one that I particularly like. And the reason that I like it is because it puts people at the centre, which I think is very important. I'm going to give you a very simple history of how did we get to where we are now with TB and HIV and why they're not integrated. It's a very, very simple version. TB treatment started out as very specialist and highly centralized, and then has gradually been decentralized. HIV treatment started much later, similarly was very highly specialized and centralized to start with. It's been decentralized very quickly, although still less completely, and the focus, I think, has been on numbers and access quite correctly, and there's been much less push towards integration, and I think that's one of the reasons why we are where we are now. Does this matter for patients? It absolutely does, and we've heard about this already. One patient, two diseases, we must treat both. You've heard about TB as the most important cause of death, but we can do something about this. So if we can improve the coverage of TB screening, we can make a difference. And these data presented by Andrew Auld at CROI this year showed that among people who were presenting to start ART, if they were screened, if there was universal TB screening using the WHO screen, followed by testing for symptomatic people, either using microscopy or expert, mortality was lower than among historical controls where the coverage of testing was much less high. So it can be done. Similarly, it's very important that people, HIV-positive people with TB, receive antiretroviral therapy. The data on the left are from the Kenya treatment program, showing that the people with the worst survival are people who are HIV positive and not on ART. And on the right, you see a meta-analysis by Anna Adoni and colleagues from the TB Centre, showing that the TB case fatality is 58% lower amongst HIV-positive people who are receiving ART compared with not. So we need to treat both diseases. There is policy on this. There has been for quite a long time, a long list of collaborative activities. The speed to which these have been implemented, however, has been quite variable. So in 2010, we were commissioned by WHO to do a systematic review looking at how TB and HIV care was being integrated and what worked and what didn't. And to help with that, we came up with this classification of systems. And at that time, most integration was being achieved by cross-referral. So just to show you the idea here, if you have a person who is diagnosed with TB, in the least integrated system, they would be referred to an HIV service both for testing and for subsequent treatment. In a more integrated system, they would be tested in the TB clinic and then referred if they needed treatment, and vice versa. And then in the most integrated systems, there would be care in a single facility. So how is that working out, or rather what's changed since then? So I think one thing that's changed is the huge roll-up and rollout of HIV testing services, much higher availability in diverse settings, particularly helped by having a low-cost point-of-care test with high sensitivity and high specificity. So the coverage of HIV testing amongst people with TB is now much higher. And so that should mean that this model whereby people have to be referred to another facility to get an HIV test should be much less common now. The other thing that has happened, again, fantastic achievement, has been the rollout of antiretroviral therapy, such that now far more people with TB are receiving antiretroviral therapy. And antiretroviral therapy delivery has been much more, although not completely, decentralized. So this single facility model is now a lot more common than it was when we did that review. But how does that play out in practice, and what does that actually mean for service integration? Because in a single facility, you sometimes have a person getting treated for TB and HIV at a single visit with a single provider with a single record. However, quite a lot of the time, what happens is that in a single facility, you have two different visits which are completely uncoordinated. You have two different providers, you have two different records, still just the one patient. Thinking about the one provider models, again, there are various ways that this has been done, and this was, we've looked at a bird's eye view of the literature rather than doing another full systematic review. But clearly there are examples of this one-stop shop providing both TB and HIV care in a very integrated way. And perhaps one of the first models of this was MSF's model in Khayelitsha in South Africa, with really very well integrated treatment for both diseases. But looking at the literature now, I think another model which has emerged and is now seems to be quite common in a range of settings is what I've called TB treats both, perhaps a bit easier to set up. So the idea here is that if you're an HIV-positive person who needs TB treatment, you get treatment both for the TB and your antiretroviral therapy in the TB clinic. And there are a number of countries, and Rwanda is one example of where this has been done. Another advantage of the TB treats both, as well as being a bit simpler to set up, it may help to address concerns which are frequently raised about TB transmission within health facilities. And I'm going to come back to that a little bit later. So, is one provider better? And we can all think of many examples of theoretical advantages, why this should be better. So from the provider's perspective, it should be more efficient to have people treated in one system rather than in two. For the patients, there are many theoretical advantages. In particular, having fewer visits should mean reduced costs, and remembering that even when services are free, the costs to patients, particularly of having TB, are very substantial and often catastrophic. But what does the evidence tell us? In practice, there are quite a few studies which report that in more integrated models of TB and HIV care, there is faster initiation of antiretroviral therapy and higher coverage of antiretroviral therapy, and that's demonstrated in this systematic review by Suter et al. But when we look at the data to see what can we deduce about the actual outcomes, so the patient-relevant outcomes, so does better integrated care save lives, it's much harder to find data on that. The evidence is much weaker. And studies tend to be small and often have historical controls, so they're not really as robust. Having said that, there's a randomized controlled trial which is currently being conducted in Durban by Kogi Naidu and colleagues, which will give us better evidence on that, so it'll be interesting to see that. If indeed a single provider model doesn't reduce mortality, why is that? And I think this is something that we really need to examine more, but one suggestion is that perhaps if you have people with advanced HIV disease, if you're waiting until they come into the clinic, perhaps it's too little, too late at that point. And what about the patient's perspective on the one provider model? So again, there has been much less work looking at patients' views on what works for them. But looking at a few more recent studies, there are some common themes, particularly the idea that separate services necessitating multiple clinic visits, which is expensive and needs more time off work, is problematic. One provider care, generally more convenient. Perceptions of perhaps better quality care in a one provider model, and unfortunately still reiteration of continuing issues with stigma. So, why do services remain separate? So, it's complicated, I think, and there are multiple reasons. Just to pick out a few, I think there's history, as I mentioned earlier. I think there's disease-specific donor funding. I think there have been, and still are in some places, differential decentralization. So HIV services still have not been decentralized to the same degree as TB services. That makes it more difficult to integrate. And then there's also perhaps more subtle issues, such as differential degree of task shifting. And to give you an example of that, in South Africa, professional nurses can prescribe ART, but enrolled nurses cannot. Professional nurses have a longer training. Most TB nurses are enrolled nurses, and that means that it limits the implementation of the TB treats both model. I've talked quite a bit about the implementation of antiretroviral therapy, which of course is very important to improve TB treatment outcomes. It's also important for TB prevention, as was shown in this meta-analysis. So people who are taking antiretroviral therapy have a 2/3 reduction in their subsequent risk of developing TB, but antiretroviral therapy for TB prevention is necessary but not sufficient, because people who are on, even people on long-term ART still have a higher risk of TB than do people who are HIV negative. And so we also need TB preventive therapy. We've had a whole session on that, so I think I don't need to say any more than that. I did just want to touch on the other of the 3 I's as they were. So intensified case finding. This is also very important. Alberto mentioned this, and so did Michelle. And I do think this is really important and an area that needs more attention. So clearly, if we want to reduce mortality due to TB, we've got to find people earlier and get them onto treatment. We've got the WHO 4 symptom screen, which is easy to do and well accepted. But it's actually quite difficult to get this to work in practice because it's not very specific. So to illustrate this is a study that we did, the X Factor study in clinics in South Africa, where we had a representative sample of people attending for HIV care. And at the first visit, nearly 1/3 of them reported one or more of these symptoms in the TB symptom screen. And that then generates a large number of people who need further assessment and or testing with whatever test it is you're going to use. If it's expert, that's quite expensive. So we really need to think more about how to make these pathways work effectively. I think it's quite difficult. So one way of doing this, for example, would be to have a predictive score. This is something that we did just to try to come up with some simple things that you could use to prioritize testing. Clearly, what we would really like is that high sensitivity, high specificity point of care finger prick test for TB. So that would be really great when we have it. While we're waiting, maybe something like this, maybe other tests, as Alberto mentioned. I think we definitely need more work in this area. The other neglected area is TB infection prevention and control, and this is often a concern in integrated care models. It's important to remember, though, that people, once they're on treatment for TB, become rapidly less infectious, and the transmission is generally from the people whose TB has not been diagnosed. There's plenty of evidence of TB transmission in health facilities. There are also plenty of guidelines on TB infection prevention and control, but generally poor implementation. So I'm involved in a project where we're trying to address this and trying to find innovative solutions using whole system approaches. And this is the Moimushle project, which means fresh air in Zulu. And here the idea is we're trying to think beyond the classic infection control measures, trying to think all the things which affect TB transmission within health facilities. As part of that, we're going to try to estimate how much transmission is happening in health facilities, but then we're going to try to look at some innovative things that might influence transmission in health facilities. So, for example, if we were to be able to decongest clinics, to what degree could that influence TB transmission within clinics? And just to give you a sort of like a flavour of that, so these are some data from the Africa Centre, Africa Health Research Institute demographic surveillance area in KwaZulu-Natal, where we just had a quick look at visits to primary care clinics by adults in this demographic surveillance area, nearly 100,000 people. And in a year, it's quite interesting that nearly 40% of all clinic visits are for HIV care. So that's really quite remarkable. So what could we do to try to decongest that? I think it would be better for people and potentially also better for TB transmission. So to wrap up then, I think what's happened over the last few years is that TB and HIV services are now more often delivered from a single facility, but the two services quite often operate independently. I think there's limited evidence that integrated services improve patient-related outcomes, or indeed that one model is better than another. I think if we want integrated TB and HIV service delivery, I think we need to want it more, and I think it may need more structural than local changes. And I think it's for certain that one size will not fit all. The landscape is changing. So yes, we want to integrate TB and HIV care, but then what about care for other chronic diseases as well? I think we need to think about that. In addition, I think we need to think about the people who are not actually in the clinics at all. So we need to think about how services address the needs of the missing people, particularly, I would say, the missing men who are missing out on both TB treatment and HIV treatment. And we need to try to improve accessibility while maintaining quality and keeping the patient in the centre of our thoughts. So I would just like to close by thanking a few people, Sanj Karat, Michael Kimmeling and Vindi Singh, for discussions about this talk, and thank you to you for your attention.